Good evening, ladies and gentlemen. Welcome to another exciting episode of academic web series Blood, the Life Saviour. Today is episode number 7. I would also like to warmly welcome faculty and the department head from prestigious St. John's Medical College, Bengaluru. I would like to welcome each one of you who take tireless effort to join despite your busy schedule. And today's topic is equally very interesting: recurrent pregnancy loss in a rare bleeding disorder. All this has been possible because of untiring effort of our course directors, Dr. Biju George, Professor, Department of Clinical Hematology at CMC Hospital, Vellore, and Dr. M. Joseph John, Professor and Head Department of Clinical Hematology. With the same breath, welcome to both of our program directors, sir. I would also like to welcome Dr. Cecil Ross, Dr. Sitaram Anandam, Dr. Chaitanya Balakrishnan, and Dr. Shushma Vaishya. As we all know that this is a short, sweet 1 hour discussion on real-life case studies. Ladies and gentlemen, it's my honor and privilege to briefly introduce our course director, Dr. B.J. George. We know him very well. Immense contribution to the field of hematology and bone marrow transplant. Dr. Viju George is professor at prestigious Department of Clinical Hematology at CMC Hospital, Vellore. Close to 300 plus publications in all the peer-reviewed journal, responsible for many innovative and standard protocols in the field of bone marrow transplant. And Dr. Biju George's areas of interest is stem cell transplantation and infection management and bone marrow failure disorder. Thank you, sir, for giving us time and guidance despite your busy schedule. Our second program director, equally contributive to the field of hematology and BMT, Dr. M. Joseph John. Dr. Joseph John is Professor and Head Department of Clinical Hematology at prestigious CMC Hospital, Ludhiana. So contribution of Christian Medical College, one from South, one from North, is immense into the field of hematology. We know sir very well, more than 30 plus international and close to 40 national publications, PI of more than 20 clinical trials. Many awards and accolades to Dr. Joseph John sir's credit also. Went on to establish the DM course in his prestigious institute. May I request both our program directors to take it forward from here, sir.
Thank you very much, and a warm welcome to all the participants for this webinar. We started this webinar in January, and every month we have hematologists from different institutions discussing real-life cases and discussing the problems that we face in routine clinical practice. So this month, we've got Dr. Cecil Ross and his team from St. John's, Bangalore, talking about recurrent pregnancy loss in a rare bleeding disorder. So over to you, Dr. Cecil.
Hi, thank you, Biju. Next slide. So if you actually take the National Hemophilia Registry data from India, the current one shows that bleeding disorders, we have a large number of factor 8 deficiency of 22,000 odd, of which about 675 are inhibitors. Then you take factor 9 deficiency, the next one, which is about 3,000 odd patients with inhibitor in that group, about 27. Actually, von Willebrand is actually small, contributes a small number, basically because it is not diagnosed, though in fact I think it's much more common than what we see. And then you have the rare bleeding disorders, again, largely underdiagnosed because of the limited laboratory resources. Now, if you take the National Hemophilia Registry, that the people who have actually looking at the rare bleeding disorders, you can see on the right from factor 13 maximum 174, factor 7 is about 125, and then factor 10 about 75, factor 11 42, factor 5 about 70, and then fibrogen 5 and 8, 33, and Glanzmann 128. Then, of course, functional plate disorder about 29, and fibroid disorders only 69. Okay. Now, I think that these rare bleeding disorders are hardly the numbers that they represent, But I think that because of the limited laboratory resources, you are not able to diagnose them. But actually, if you start looking at them, you will get the numbers that are matching the international numbers. Because I don't think that there are much so less group of average disorders in the country than what you would expect in the international area. Next slide. Now, what we will do is that I want to discuss this whole thing as the congenital fibrinogen deficiency. This is a paradigm in a reproductive health. Because you see, people who got recurrent pregnancy loss, that means defined as loss of 2 or more pregnancies occurring consecutively before the 20th week of gestation, that is the recurrent pregnancy loss. Normally, when the patients have got the recurrent pregnancy loss, you think of genetic or chromosome abnormalities, uterine structural problems, endocrine disorders, autoimmune factors like antiphospholipid infection or lifestyle disorders. The clinical importance of this is that when you get as a hematologist, you know that about 1 to 2% of the couples that come to a hospital or in the general population get this recurrent pregnancy loss, unexplained various reasons why they are not able to conceive or they abort. And from hematology standpoint, normally the commonest ones which we get across is APLA and secondary ATP, the most common. And they usually get ruled out because these are usually now managed by most of the obstetricians. And we come only peripherally or at the time of perioperative, post-operative management. But otherwise, they manage usually with the low dose aspirin, steroids, and things like that. So sometimes after all this, still there is a recurrent pregnancy loss. Then we need to know whether these are rare bleeding disorders, and that is what we will discuss now with such a patient and use this as a paradigm to be able to discuss the various nuances of congenital fibrinogen deficiency. Over to you, Sushma.
Yes, sir. So I will briefly discuss the case over here. So basically, a 23-year-old female was referred to us from a periphery hospital for prolonged bleeding in her right forearm in July 2023. And she was evaluated at the same hospital and found to have a prolonged PT and APTT. And she was managed with 3 units of FFP and was referred here. She also gave a possible history of prolonged PV bleed, about 5 to 6 pads per day for 10 days, in her last abortion, for which she received some transfusion which she was unable to specify. However, she did not give any history of menorrhagia or any other significant bleeding in the past. However, this lady has been married for 5 years and has a very bad obstetric history. She has 4 spontaneous abortions at 2 months each. But even when asking in her previous abortions, she told that only in her last abortion she had significant bleed. On clinical examination, nothing significant was seen. And we evaluated further with complete coagulation profile, which showed an HB of 10.9, platelet of 2,27,000, BT of 4 seconds, raised PT and APTT. PT was 180, APTT was 120 seconds, and the thrombin time was more than a minute. All of the above were corrected with the control plasma. We further went ahead with the fibrinogen assay and we found it to be less than 10 milligram per deciliter, and a diagnosis of afibrinogenemia was made. That during that time she was counseled regarding periconceptional fibrinogen replacement and was directed to a government center to procure fibrinogen. However, she was referred back due to non-availability of the same. In July 2024, she presented to us at 4th week of gestation, her expected date of delivery being 31st March 2025, and we started her on 6 cryoprecipitate, roughly 1 gram of fibrinogen per week until 8th of August 24, when she got admitted for spotting PV. We continued with her cryoprecipitate infusion with a target fibrinogen level of 100 milligram per deciliter along with a regular OBGYN review. As we can see in this chart, the first one is in the OPD visit where the fibrinogen level measured before she received the cryo was 35. That's because she has got some FFP and cryo in the outside hospital and she came to us. Then over her admission, only in the last day of discharge, that is on 17th of August 24, we were able to achieve a fibrinogen level of 101. In previous days, it was somewhere around 50. And again, she was discharged on 17th of August, and she came back to us in OPD, and we rechecked her fibrinogen level on 27th of August, and that was 15. From September 24, we changed to 10 units of cryoprecipitate per week because she kept on telling that she has recurrent mild PV bleeds, about 1 to 2 drops, and we used to send her to OBG OPD, and they said there are no features of threatened abortion. So we changed from 6 units to 10 units. And as we can see, even during the month of September, once we were able to achieve a fibrinogen level of more than 100, but beyond that, it was somewhere around 10 to 30 only. Then she got admitted on 24th of December 24 with threatened abortion. And again, we continued with the same transfusion of 10 units of cryo per day. And she received tocolytics and 2 doses of betamethasone for fetal lung development. We had a tough time handling her during this period because in her last trimester, we were not able to achieve a good fibrinogen level, not beyond 50, until 31st of December, where we were able to achieve a fibrinogen level of more than 100. And on 1st of January, she was again discharged. Then she followed up in our OPD from here on twice a week, and we started her on 10 units of cryo twice a week, and we carried her pregnancy till 8th of March 2025. Even though she was getting 10 units of cryo twice a week, still the fibrinogen level was quite low. Then at 36 weeks of gestation, she was admitted under OBGYN for pain abdomen. And on 10th March 25, she underwent LSCS at 1 p.m. because of fetal distress, and she received 10 cryoprecipitate prior to induction. So the day of admission was 8th of March 25. So 8th, 9th and 10th, she got 10 units of cryoprecipitate. As we can see in the graph, on all these days, we were able to achieve a fibrinogen level of more than 100. And then post-delivery also, she was transfused with 10 cryoprecipitates daily, and a fibrinogen level of more than 100 mg per deciliter was maintained until post-op day 5. And we did not encounter any further bleeding episode. And she was discharged finally on 16 March 25 with a healthy baby boy. And this photo has been put up after patient's permission, and she was quite happy, and she visited us after a week of her delivery. Thank you. I share over to Cecil, sir.
So this lady, in the government setup, we normally would say that this fibrogen is available in the market, and they would get fibrogen from various schemes in the government, RSBY or Janani scheme and things like that. But somehow or other, this lady was not able to access that. So we had to manage with whatever we could after 4 abortions. Cryoprecipitate, and this is quite a difficult challenge for patient also, because she has to come twice a week, and she lives in Tamil Nadu, close by, Hosur or Krishnagiri, somewhere there. So that was the issue, but we managed and got the whole thing. Now I'll ask Chaitanya to discuss this issue in the light of what fibroid disorder. And like I told you, it is people with recurrent pregnancy loss without any other cause, and you get sometimes stumped like this, and then you have to look at rare bleeding disorders and other causes, etiological causes of recurrent pregnancy loss. So I'll hand over to Dr. Chaitanya.
Good evening, everyone. Thank you, sir. And thank you, Sushma, for the presentation. So as sir had mentioned and Sushma had outlined, we had a lot of challenges dealing with this patient, especially given the recurrent pregnancy loss prior to this current pregnancy. There was a lot of apprehension with regards to how we were going to manage it, both on our side as well as the patient side, understandably. So if you look at the definitions, there have been quite a change in the definitions of recurrent pregnancy loss. If you look at the RCOG in 2011 till the ESHRE in 2023, there have been certain changes. While the RCOG guidelines still hold good, the ESHRE guidelines are what we generally follow, which is 2 or more failed pregnancies. They do not have to be consecutive. This is one change that we have noted, confirmed either by a urinary or a serum gonadotropin, and this doesn't include ectopic or molar pregnancies. Generally, these usually are anything less than 20 weeks. The French group says less than 16 weeks, but generally 20 weeks is what is acceptable. As Cecil sir had outlined, generally when a lady comes to us with recurrent pregnancy losses, and I just put up all the causes with their percentage of contribution, how you're recommended to screen them. You see that cytogenetic abnormalities, antiphospholipid antibody syndrome, anatomic uterine abnormalities, hormonal or metabolic causes, infections, male factors, alloimmunization, environmental, occupational, or personal habits are always the top runners. And this is from the ASRM guidelines of 2025, where this is what you're required to screen. And if you look at it, none of the guidelines really mention, and if you put problems or disorders of blood leading to RPL, you will usually get hereditary thrombophilia or APL. So in our patient, or generally in pregnancy, do you have bleeding disorders which cause difficulty to the hematologist? Absolutely. And the commonest, as Sir mentioned, which is often underdiagnosed, is actually von Willebrand. So hemophilia and one carrier status as well as von Willebrand are supposed to be the biggest contributors. Thrombocytopenias of various etiologies, usually immune platelet dysfunction disorders. And in the last line, defects of fibrinolysis, connective tissue diseases, and other coagulation factor deficiencies, which come under the rare factor deficiencies, out of which fibrinogen is one of them. To note, of all the clotting factor deficiencies which are inherited, factor 13 and fibrinogen are the ones which are commonly associated with recurrent pregnancy loss. There has been data on factor 5 deficiency also contributing, but these are the two most important. And the reason is that the cross-linking between 13 and fibrinogen is required for placental integrity right from the right from the beginning of pregnancy, which is why patients tend to have recurrent abortions, especially in the first trimester. Coming to the ICETH classification of 2018, where they realized that we have a group of disorders which are referred to as congenital or hereditary fibrinogen disorders, are actually multiple subtypes. And this we've known for a long period of time based on data that showed that patients who had a fibrinogen disorder could either bleed or clot, right? So you have a bleeding profile as well as a thrombotic profile. So we have 4 types. You have afibrinogenemia, where there is undetectable fibrinogen in the blood; hypofibrinogenemia, where the levels are reduced; dysfibrinogenemia, where they can either be bleeding or thrombosis, one of the two; and the last is hypodysfibrinogenemia, where you have not only the risk of bleeding or clotting, but also lower levels of fibrinogen. Key to note that afibrinogenemia is autosomal recessive. The other 3 are generally autosomal dominant disorders, and again, difficult to diagnose and often missed. Coming to the HFDs, as they're called. So like I said, they're a heterogeneous variety of disorders, and the incidence is usually 1 in 1 million. Again, chromosome 4, you have 3 predominant genes, FGA, FGB, and FGG. And afibrinogenemia, which we're going to talk about today, is the complete absence because of a homozygous autosomally recessive inherited mutations in the FGA. Now, when you do a data search, there are almost 50 different mutations in the FGA, which have been described in various hereditary fibrinogen disorders. So this is something that's developing with, of course, the advent of NGS. This is overall data showing from 25 countries with 204 patients, both adult and children, just showing the burden of this disease, right? And we see that they can have both a bleeding as well as a thrombotic phenotype, especially commonly in adults. You see that the number of patients with a thrombotic profile was much more identified, and it also has an impact on their quality of life. Most patients who have a fibrinogen disorder, afibrinogenemia, tend to present with bleeding issues. So you have, especially in adults, menorrhagia, muscle hematomas, hematorosis akin to a hemophiliac, bleeding on tooth extraction, epistaxis, and other bleeds as well. But one very important point to remember in patients with HFDs is the thrombotic potential. And the reasons for it are multiple, but the main thing is when you have severe afibrinogenemia, there's sometimes uncontrolled thrombin generation, which causes addition to platelets and activation of them. So that's why they have the paradoxical clot. And this can also occur during treatment of AF fibrinogenemia with replacement products, which I'll come to subsequently. What about pregnancy in HFDs? As Sushma had outlined, this patient had history of recurrent pregnancy loss. But you can also have stillbirths, you can have abruptio placentae, you can have IUGR, and of course, what we normally expect, the bleeding phenotype, vaginal bleeding, PPH, even APH has been described, and of course, thrombosis. Now, this thrombosis, especially in pregnancy, which itself is a prothrombotic disorder, can occur during the period of pregnancy, during the period of labor and postpartum, and especially when these patients are on replacement. So the paradox here is when you're replacing fibrinogen in these individuals, their thrombotic risk goes up, which is something we look at. So this is a review article from the World Federation of Hemophilia, which looked at the complications in women with HFDs. And they studied about 188 pregnancies from 70 women. And they found a strikingly large number that half of the pregnancies resulted in miscarriages, right? And this is found in patients who had afibro, hypofibro, dysfibro, and hypodysfibrinogenemia, respectively. Metorrhagia in the first trimester was seen in 21.7%. Abruptio in various amount of patients in the diseases. They had 24 of the deliveries were complicated by postpartum thrombotic events, which is why and postpartum hemorrhage, which is why the monitoring of such a patient, even post-op, up to 4 to 6 weeks post-delivery, is very, very important. So how do we diagnose? As I said, we've rarely had patients who've come to us at a later stage for diagnosis, but we have seen patients who've diagnosed for the first time when they've been evaluated for RPL. And classically, you do a PT, APTT, and you need a thrombin time prolongation, especially for fibrinogen deficiency. One thing to note that especially in factor 2 and fibrinogen deficiencies, the PT APT may be normal, especially if you have a milder deficiency. Again, we do the mixing studies to rule out inhibitors. Two tests that are very important in patients with AF fibrinogenemia are the functional class assay as well as the antigenic assay. Because as we know, the fibrinogen deficiencies are a spectrum all the way from AF fibrinogenemia to hypodys. And only when you use correlate the class assay to the antigenic assay will you actually be able to pick up the patients who have hypodys or even or dysfibrinogenemia respectively. Again, nowadays with the advent of genetic testing with NGS, we can do for the mutations of FGG, B, and the FGA genes as well. This was published in a thrombotic guideline, which showed that inherited disorder or bleeding disorders in pregnancy, how are the risks stratified? And as you can see, this is a comprehensive involvement of all bleeding disorders. The one that we are involved with, if you notice, fibrinogen deficiencies comes under the group of rare severe homozygous coagulation factor deficiencies, which have a very, very high risk of bleeding. And if you look here, it does clearly mention that you need to maintain normal factor levels for more than 3 days after vaginal and 5 days after the cesarean section. I'll come to that subsequently. One important thing that we all face when we are treating patients with a coagulation deficiency, clotting factor deficiency is, does the degree of factor deficiency correlate clinically and to the lab? And for us, luckily, fibrinogen, their clinical and laboratory correlation is strong. So you can expect that if you've adequately replaced fibrinogen, the clinical phenotype is potentially predictable. Unlike other factor deficiencies where you see there's a weak correlation, like in factor 5 or even in factor 7. Now, how do you manage? And this is where the challenge came in for us. This is a lady who's had recurrent pregnancy loss, pregnant again. And this is obviously a very, very precious pregnancy. So in women who have afibro and severe hypofibro, given the risk of spontaneous abortion, ideally factor replacement must start and continue as soon after conception and pregnancy confirmation. And as we know, we need to target a trough fibrinogen level of 1 gram per liter. And this is our target throughout the pregnancy. Again, we have various products for the replacement, which is cryo, pure fibrinogen concentrate, or even FFP, which is used in some centers. Again, maintaining targets may be difficult with FFP, but ideally during the first and second trimester, 0.5 to 1 gram per liter should be the target. Again, even in women who have mild or moderate replacement to maintain a trough level of more than 1 is indicated. Otherwise, abruptio placenta incidence is much higher. So how do you monitor such patients? So ideally, in the first 1 month, when you start fibrinogen replacement, weekly trough levels are required, and then you need monthly to maintain the target levels of 1. And if you're using a PD fibrinogen concentrate, we have to do a pharmacokinetic study because this actually tailors the dose to this. The reason is, as pregnancy progresses, there is an increase in the fibrinogen dose requirement. And the reason for this is that there's increased fibrinogen clearance as the pregnancy progresses. So as you saw in our case, which Dr. Sushma outlined, that the frequency of cryoprecipitate transfusions or infusions started going up. So some patients we had transfused at some point almost daily for a couple of weeks. But ideally, sometimes patients will require bi-weekly or even tri-weekly fibrinogen replacement based on the trough levels, especially in the third trimester. One thing to note is every time you evaluate the patient when you're planning to give replacement, you need to look at the thrombotic risk, especially if there are other risk factors for it. And if you feel that you need to dose adjust because the risk of thrombosis is going up, change the frequency of administration rather than the dose. To try to maintain the frequency should change, but try to maintain the dose. So in women who have AF fibrinogen during labor, again, vaginal or cesarean, they have done a lot of reviews to see whether which method, of course, is different, but is better. But the RCOG says that either a vaginal or a cesarean section, there's no difference. Of course, in women who have mild hypofibrinogenemia, spontaneous labor and vaginal LD should be allowed. Monitoring of fibrinogen level during delivery due to consumption should be done at the time of labor and every 12 to 24 hours, especially for the first 3 days in vaginal and the first 5 days in cesarean section. And target is about 1.5 gram per liter for the 3 days after a vaginal and 5 days after CS. And to prevent secondary PPH, or if they have on prolonged or heavy lochia, you can use tranexamic acid with the caveat that the thrombotic risk has to be again assessed at this point of time. If you find that the thrombotic risk is higher, then you may try to avoid giving tranexamic acid unless absolutely necessary. The last paragraph which I mentioned today was something I found in a recent or 2021 ASH guideline, which said that they tend to consider the patients on fibrinogen replacement, pharmacological thromboprophylaxis with LMWH until discharge, especially if the woman has additional thrombotic risk factors. And this is given extension based on the patient's phenotype, especially if she's a afibrinogemia or a hypofibrinogemia with a thrombotic phenotype. It may be worthwhile to consider giving LMWH while on fibrinogen replacement for 4 to 6 weeks post-delivery. Again, this is just showing the target that you ideally 1 to 1.5 gram per liter. You can either use fibrinogen concentrate, which is the one that we all would like to use, but because of various financial constraints and the settings that we treat patients in, solvent adjuvant treated plasma, cryo are usually what we unfortunately have to resort to. So this is just a schematic which summarizes what I said. If you, for any rare bleeding disorder, not just specifically afibrinogenemia, consider prophylaxis if the factor levels are less than 50, again, considering which stage of pregnancy you've tested in. Again, the basic group and screen for the coagulation, do the clotting factor levels. It always requires a multidisciplinary team approach involving OB or maternal and fetal medicine, hematology, anesthesia, and neonatology. Again, neuraxial anesthesia based on the risk assessment, invasive fetal monitoring, trying to avoid a prolonged labor or a traumatic labor or an instrumental delivery. And again, assessing the neonatal coagulation status, avoiding IM injections, or sometimes even giving vitamin K to the neonates is something that the neonatologist may advise. This slide just summarizes how you should ideally manage a woman with afibrinogemia or hypo during pregnancy. And I thought this encapsulates it perfectly. This is mentioned start preconceptional fibrinogen replacement. Again, may be difficult in our setup, but the antenatal care, as we have mentioned earlier, is weekly fibrinogen replacements. Trough level 1 gram. If you have vaginal bleeding, increase the level, target level to 1.5. And thromboprophylaxis is the same as the general population. But if the patient has other thrombotic risk factors, do consider changing the frequency of giving fibrinogen rather than the dose that you're giving. During labor and delivery, there's no difference between vaginal and cesarean. Maintain about 1.5. And you should check postpartum at least for 3 days after vaginal and 5 days after cesarean. Again, trying to maintain 1.5. Patients on fibrinogen prophylaxis never forget conventional LMWH thromboprophylaxis post-op because of the risk of thrombosis. And again, tranexamic acid should be used only if there's postpartum bleeding. And this is a paper which, again, in a blood visual abstract, which showed generally how you treat if they're acutely bleeding. If they're presented with thrombosis, you need to do surgery or pregnancy. And I thought this beautifully captures how you should treat a quantitative fibrinogen disorder in all its forms. If the patient's acutely bleeding, going for surgery, if they're presented with a thrombotic profile, or they're pregnant. And I think this should tell us exactly how to treat. My last slide would be generally what we use. So if you're using a plasma-derived fibrinogen, then 5 to 10 mg per kg. If you're giving on demand for bleeding, prophylaxis becomes 20 to 30 mg per kg once a week, with a target during pregnancy of 1 to 1.5. If you're giving cryo, as we know, one pool or unit of cryo is about 15 to 20 ml, one bag, and it contains about 150 to 250 mg of fibrinogen. So classically, we say one bag per 10 kgs every 7 to 10 days if you're giving long-term prophylaxis. And FFP is about 15 to 30 ml per kg. But again, this should be the last option that we use, given that you are not able to predict how much fibrinogen is it's going to rise by. And that's about 15 to 30 ml per kg. If you have recombinant fibrinogen, then this is the formula that we use, provided you have the patient's measured level and your target plasma level. And this is the formula we use when we are replacing with the plasma-derived fibrinogen. So in summary, I'd like to hand the screen or the thing back to Dr. Cecil. I just like to say that, again, the complexity of handling this case was something that we all encountered right from the time that the despair of the lady to have so many recurrent pregnancy loss, and how we were able to manage, one, the distance of coming all the way to our hospital for cryo, the need for increased cryo demand during her third trimester, and the challenges that we faced with maintaining her trough level of fibrinogen so that she didn't lose this pregnancy, and the complications that we were able to surmount during her delivery. So identification, I think, of a rare bleeding disorder like the HFDs is extremely important. And it does require a very strict protocol and a very structured protocol from all teams involved to ensure the best outcome for mother and child. Over to Cecil, sir. Thank you.
Yeah, thanks, Krishna. Thanks, Chaitanya. Actually, I wanted to...
Sir, I think there is a couple of questions in the chat box.
Yeah, before that, I think... Okay, let's see.
No, we will do that after Dr. Cecil gives his comments.
Yeah, so I just want to provoke Joseph John. Joseph John is joined. I just like to provoke him because you had many discussions and arguments regarding this. So I'll do one thing. Can I share a slide? Can you permit me to share the slide?
Yeah, sure.
Okay.
You can share now.
Okay, so it is just for information that if you take people causes of maternal mortality in our country, okay, this actually is surprising that when you look at obstructed labor, sepsis, anemia, blood pressure disorder, hypertension in pregnancy and others, bleeding constitutes about 30% of women who die of bleeding. Okay, so if you take all the maternal mortality, bleeding is about 30%. And the only solution that you have, which is evidence-based, is oxytocin, manual compression, empiric stuff. Okay, sometimes people give unexplained bleeding, PPH, they give factor 7 or something like that. So I just wanted to impress upon it. And then if you look at the chapters that are there in the country, it actually correlates with the number of chapters that are there, which the mortality rate is reduced. Now, supposing you take places in the north, okay, especially Rajasthan and UP and Delhi and Himachal, the MMR is more than 300, and you look at the number of chapters that are there. Whereas you take the south, so you can see the density of the chapters there, and if you look at the green areas, it's less than 150. So I'm just trying. Joseph John has done some studies on this and extrapolated and said that there is no correlation between the total number of chapters that are there in hemophilia treatment centers with the maternal mortality rate in that area. To look at the global. Now, my only argument is that if you have got HTCs which manage bleeding across the spectrum, maybe hemophilia, von Willebrand's, or any bleeding disorder, dengue or whatever. Okay, and if that capacity in that area is higher, basically because the HTC will now be able to handle bleeding, there will be some kind of a laboratory, there will be some kind of a infrastructure that will be available. So I suspect that the bleeding due to maternal mortality rate due to bleeding could be reduced. Okay, this is just empiric data, and I'll throw this off to Joseph John.
Yeah, that is an interesting thing, but I don't know whether the number of HTCs wise correlation does matter or not matter. I think it is still worth HTC. All HTCs does not have laboratories. So here you are having the challenge of having a laboratory. Sorry?
HTC, expand HTC. HTC.
Sorry, I didn't get it.
No, expand HTC, I think. Many people may not know what the HTC is.
Oh, okay. So Hemophilia Treatment Center is basically a place where we are defining, there are various definitions, but we define it as a place where a patient of person with hemophilia or a PWH can get his care done. It may or may not be attached to a laboratory who will give a coagulation service. If they do not have a laboratory nearby, they are sent to a coagulation lab. Now, if you have a coagulation lab, they are equipped with doing factor assays, including fibrinogen assay, if they can set it up. Otherwise, PT, APDT at least will be done, and your fibrinogen abnormality can be picked up on both the abnormalities. So, irrespective of whether maternal mortality rate is proportional to lack of HTCs or lack of laboratory, it may or may not show correlation, but if it shows a correlation is fantastic or an association is fantastic. Even in the absence of it, to have a coagulation lab which can do these basic tests will be of use. So I think the take home can be abnormal bleeding, which is not fibroid. Instead of saying it is only DUB, even if they do not have bleeding from anywhere else, it is worthwhile doing a BAT scoring, that is a bleeding assessment scoring can be done, and do further coagulation checkup. If the PT-APDT is not correcting, you can send them to a local coagulation lab.
Joseph, just take the questions forward. I think there are a few in the chat and Q&A. Okay, I think there are a few questions which are there, and so the first one, I think, from Venkat, is there a role doing NGS to identify thrombotic phenotype in fibrinogen disorders? Either Dr. Chaitanya, Dr. Cecil, and then Dr. Joseph.
What's the question?
The question is there any role in doing NGS?
Oh, yeah. Okay.
To identify thrombotic phenotype in fibrinogen disorder.
So I think that, because NGS is available freely, it can be transported across the country, and it is quite simple to do NGS. Only thing is a little costly, but instead of, I would say that supposing you have a bad score like what Joseph John was saying, and then you don't have the facilities to do PT, APTT, which are coagulation-based assays, and a lot of technician dependent and technology dependent and lack of reagents. That's what we see across the country. In which case, you can just do an NGS, send it to them, cost some 10,000-12,000 rupees, and you can get a panel and get a diagnosis. So instead of doing all this in this, coagulation, PT, APTT, TT, then coagulation mixing, and then factor assays, and so on and so forth, which costs about the same, might as well do an NGS. I think that, it is a provocative thing to say, and a provocative thing to think of, to be able to say that, bypass all this whole thing and just get an NGS, provided there is a history which is very, 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 very critical. There is a bad score that actually tells you it's more or less than 5 or 6, and then you then do the NGS.
So I think, Joseph, you want to say anything about doing NGS?
So like he said, it is now coming in. People are saying that doing NGS can be cheap, which can be done in 200 rupees. But that is a story which is yet to unravel. But there are von Willebrand's disease is something which can be picked up, I would say, with a spot test, which is available now. KEM has developed that, and that will be a good option to consider to do a spot test for von Willebrand's disease. That may solve the problem. Fibrinogen deficiency may be a pretty rare occurrence there.
So, Joseph, the question also was, okay, one is diagnosing a fibrinogen disorder. Two is identifying the thrombotic phenotype. So, can we identify who's likely to have thrombosis? Is that possible through NGS?
So can I comment, sir?
Yeah, please comment.
So, I mean, yeah, that's the thing. Because if you look at our patient, she's kind of, achieved the age of 23 with no major bleeding disorder. So, with a severe fibrinogenemia, she's gone through all her life with hardly any bleeding. And the first time when she presents was a bit of a minor bleeding. So we don't know whether she's a thrombotic tendency or a bleeding tendency, or she's got both. And I think given our numbers are so less, it is very difficult. We should probably look at our own data to see how the NGS will help us. It certainly will help us. And in this particular patient, we were quite restricted by the finances. So we actually had to support her cryo ourselves. And in fact, you could see the variation in the fibrinogen levels because most of the tests were kind of supported by our department, which is why we could not do it in an orderly fashion, just educated guesswork. So in my view, NGS certainly will play a role, but the clinical phenotype of the patient we also need to take into account, and then take a call is what I feel. So.
Okay. The other question to the team now, what surprised me was the fact that this lady had 4 abortions so far, and generally for a gynecologist who sees once you go above 2 alarms sound, and at least they look for lupus and they would do an APTT. And the APTT actually would have been picked up as prolonged. But from what I understand, nothing was done throughout the 4 episodes of abortion. Is that correct?
Yes, sir. No test was done until and unless she bled from her right forearm. That is when they caught the raised APTT. And sadly, in her last 4 abortions, no, even when she bled so much in the last abortion, they just gave her, from what she explained, looked like FFP, and they just kept at that. Yeah.
Okay. So there are 3-4 other questions. So the first question is, why did this patient not increment her fibrinogen levels despite adequate cryoprecipitate, though she was transfusion naive initially? I think the question was, it took 2, 3, 4 days of cryoprecipitate infusion for you to actually get up to your 100 levels. So is there any specific reason you think why that happened?
So, this is an interesting thing. I mean, we've not managed many patients with hypofibrinogenemia, or at least I have not managed, with pregnancy. And we were actually in some ways learning as we were going along. And one thing we can think of is whether there was increased consumption because it was mainly towards the latter part of second trimester and the third trimester, her requirements went up significantly. Or whether there was a role of hemodilution, increased consumption, we don't know the answer. And also the second thing was that we were giving her cryo. So we actually didn't know how much of, fibrinogen content was there in each bag. We did not have enough resources to actually check every time. So ideally, we should have checked pre, given her cryo, and checked post. And then we could have made a informed decision for the next one. So we kind of were handicapped by the resources, I would say. But certainly, I think there's increased consumption in the latter part of second trimester and third trimester, which is why she required more cryo. And the interesting thing is post-delivery, if you see, we were able to manage her cryo our levels quite easily, and we reached super 100 levels. So certainly, I think the pregnancy played a significant role in second and third trimester.
So if I may,
So actually,
Yeah.
the fibrillation also an acute phase reaction. No? So at the back end of the pregnancy, the endogenous fibrillation will sort of be better or
Go up, sir.
consumption may be less. So I don't know. The other thing is, you see, I believe, I mean, I don't know, because this is this case, say, for example, you're not maintained 100% or so, but approximately if you take the average out, looks about a trough level throughout the pregnancy, an average good guess would be 50-60%. And I think we are managed with that 50-60% to maintain the pregnancy. And at the end of it, and the term time, we have increased it to about 100%. And we're not burnt our fingers. Now, supposing you look at other bleeding disorders also, you don't need 100% or whatever the Western literature would say. You just need about 50%, 60% of correction to be able to maintain the pregnancy. It's not necessary what the literature says that you have to maintain one trough level of 1 gram or so. Because even if you want to maintain trough level 1 gram or so, the amount of fibrinogen concentrate that you need, the frequency, if you don't have, you just have fibrinogen. Maybe that it will precipitate a thrombotic event in such patients. So that is another worry. And I think the safer thing would be to maintain a 50%, 60% trough level, and then manage the pregnancy full blown at the time of delivery.
So if I'm,
The other thing I think is also, yeah, please go
sorry,
ahead, Chandani.
a couple of things. So one is as I was mentioning, the second and third trimester, they do tend to have increased consumption of fibrinogen. So there was this one case series, one of the few case series which looked at this. I think they did 11 consecutive patients. It's a small series, but then I went through their literature and they all noted that at least 80% of their women required almost thrice weekly cryo, especially in trimester 3. And one of their references also said that they had one of those patients, in fact, the last 3 weeks of her delivery needed almost daily cryo to maintain that trough. So I think that's the challenge that we've also faced. Secondly, pre and post cryo, there was another paper which showed measuring pre and 30 minutes post finishing of cryo. And they found that the dose that they calculated to give the amount of cryo to reach 1 was often the patients never reached 1 post that cryo. They never reached the trough level. And that again, it's a pooled cryo, our population. So it's very difficult to predict. The third paper I'd like to allude to said that if you're using FFP or cryo, because you cannot afford fibrinogen product, even if you maintain say 0.5 to 1, you should be able to get away with the pregnancy till the delivery. It's that last trimester and labor, I think, which pose the biggest challenge.
Okay. So the next question is, how do we manage preconceptionally in a lady with menorrhagia planning to conceive? Or even if you take this lady and she comes 1 year later saying, I would like to become pregnant again, how would you go about trying to manage her?
Yeah, I think that the day HCG is positive, I would start prophylaxis because we have a history of recurrent abortion and 4 pregnancies lost, and now she's got 1 child, and at least the child is 2 years old. Would like to manage her in a similar way to maintain a trough about 50-60%. And start, because this lady came at 20 weeks of gestation. We would start at conception. The moment the HCG is positive, gonadotropin is positive, biochemical pregnancy, we start prophylaxis, maintaining about 50% or so.
So is there any group of patients where you would consider fibrinogen replacement as well as thromboprophylaxis?
Oh, we have got a couple of guys on the board. But Chaitanya, I would want to say that one fellow has come with IC bleed, thrombosis, multiple channels of thrombosis, IC, and the other chap is acute pulmonary embolism with bleeding.
Yes, sir. So
we've got 2 guys on the board at the moment.
Yes, sir. So one of the patients is actually, extensive pulmonary thromboembolism. He's got a clot in the LV, both pulmonary arteries, but he's more of a hypodys type of phenotype. PTA pretty extremely prolonged correcting, and his fibrinogen level is about 12. So he's somebody who's presenting like this, who we're facing a extreme challenge because we have to replace fibrinogen, but the treatment dose for anticoagulation is a must. So maintaining that balance, and especially how you're going to monitor his therapeutic anticoagulation activity is also important, especially with anti-10A levels being not so easy and not so affordable for everyone to regularly do.
Okay. So The next question is, based on this case experience and the difficulty in accessing fibrinogen products, do you think we can target lower trough levels and carry a pregnancy through?
Yeah, I think I've answered that. I mean, I think that you have to probably maintain a trough level of 50 mg per deciliter, and that should be enough. Supposing if you still then keep getting bleeding or threatened abortion, things like that, then you would hike it up to 100. But if the person is not getting bleeding, and also I would then think of monitoring the ultrasound to see the fetal growth. And if the fetal growth is going smooth, there is no IUGR and there's no bleeding, I would maintain till about 50 mg per deciliter and then hike it up to double the dose if there is bleeding or threatened abortion.
And the other question is, so how easy or difficult is it to get fibrinogen concentrate?
Oh, it's easy. I mean,
available.
Yeah, Intas makes fibrinogen, costs 14,000 rupees a vial, and this would actually cost 28 to 30,000 rupees a week. So that is the cost that you're talking about. So 9, 4, 12, so 1.2 lakh per month. So about 14 lakhs, 15 lakhs per year for the whole pregnancy. So it's big money. So therefore, we actually thought that we should be able to get the government support, because you know what? See, in case you make a case and you make a plan and give it to a center which actually has got factor access to its products, and the gynecologist there or the physician there is a little motivated and he is proactive in getting the lady into a scheme which is Janani scheme or RSBMS scheme. There are schemes that are there in the government setup which you actually can, in such conditions, make a case and procure the fibrinogen concentrate and then give it as per protocol. So it needs a lot of advocacy, a lot of patient interaction with the concerned doctor. The doctor should be proactive in getting that, because he feels compassionate and challenging for him or her to manage it. So that's what we try to do, but again, because of the interstate problems of getting access to the factor based on the Aadhaar and other things, it becomes a problem. But otherwise, I think within the state, if the person has got the schemes that you can actually get into, it should be possible to treat it like in the textbook, because there are a lot of schemes in the government which will actually help you support.
So I think most of the questions are over. So just one more question. So you had talked about the fact that you've got two patients who've got fibrinogen deficiency and has got thrombosis.
Yeah.
So in such patients, just for everybody's sake, what would be the sort of fibrinogen levels you would target there? Would it be a lower level because you don't want to go up too high and promote thrombosis further?
No. In that case, what we are thinking is that we give them full 100 mg, 100% level, and then anticoagulate. Make the flow as normal as possible, and then give anticoagulation full start. So this patient, what we are doing is we just today, I think we have done the IR fellows have done the clot evacuation to be able to say that to establish the patency of the pulmonary artery, and we are giving him full heparin, low molecular weight heparin, 60 and 80, something like that, twice a day, and giving him full cryo to maintain a factor level of about 80-100. So that the acute care will be. The point is, after that, what you're going to do is a big problem. So whether you would give Debigatran, or whatever, Duox or Noax or whatever, be able to maintain the guy, because this guy has come twice, with the second pulmonary embolism, thrombopulmonary embolism he's had. Once he stopped the anticoagulation on his own and then got a recurrent problem. So this guy, the third time he gets pulmonary embolism, he may be dead. So we have to make a long-term plan for him to maintain him on a chronic anticoagulation of some sort and then manage. The other guy is a little more complicated. I mean, he's got CNS bleed, and that fellow's got arterial thrombosis. If he's got arterial thrombosis, maybe we would manage with aspirin and maintain a rough level of, say, 30-40%. That is simpler, but this guy is a little complicated.
Right. Sir, I would quite like to know your views, because the way I see it is this patient has a problem with a fibrinogen, which is dysfibrinogenemic. Okay. We are actually replacing with a normal fibrinogen. So if you're able to achieve the adequate levels of, say, 100, he should have normal fibrinogen and we should be able to adequately anticoagulate him, at least for the initial period of 6 weeks at least, is my view. So we would actually like to know what the practice in CMC is. So
Yeah, I don't know. I totally agree. We would do the same thing. We would push the fibrinogen and get it up and do the adequate anticoagulation so that I think that initial 1 to 2 weeks is very crucial if you want to get good control in terms of the thrombotic event that is going on. I think the bigger challenge is what happens after that. How do you maintain and how do you maintain both the fibrinogen as well as in terms of your thrombosis and have that fine balance between making sure that the thrombosis risk does not increase as well as the bleeding risk does not increase. So that I think long-term challenge is going to be high, and especially if it's somebody who's already had one thrombosis and it's a recurrent thrombosis, we are now looking at lifelong anticoagulation, definitely. Now there again, are you going to give lifelong fibrinogen replacement along with anticoagulation? Is something which you need to look at. Going to be difficult managing this person.
So we had a patient who actually is now coming on follow-up. He's got afibrinogen deficiency. He was on a clinical trial with fibrinogen concentrate. The fibrinogen availability was not an issue. We gave him fibrinogen, but the fellow, when we gave him fibrinogen, when he had the bleeding, he started clotting in his toes. So then we had to give him aspirin and then steroids, thinking that it is not related to fibrinogen, or maybe, because ESR was slightly high or whatever. But then he started bleeding, clotting, and then we had to amputate his toes, and then further progress, then we had to amputate elbow ankle. So while the patient is on fibrinogen for some bleeding somewhere, and he's clotting elsewhere, and we actually had to amputate him. Now he's on a complete amputee with a prosthesis. So it becomes difficult. Even if you have adequate fibrinogen, we are giving him fibrinogen. The fellow is now on a wheelchair, but of course he comes on a wheelchair to the OPD, but he is able to walk and all with the prosthesis. And so that is another problem, that even if you have fibrinogen, you can't really put it up 100% for a long time, especially when the fellow's got a bleeding. Say, for example, you got apogea bleed or some other bleed, tooth bleed or something like that, and you want to maintain the fibrinogen because it's got adequate stuff is there in the clinical trial, and you follow the clinical protocol because you can't do otherwise become a protocol deviation. So you follow the protocol and then you land up into this. So it is a dicey business to be able to manage even if you have fibrinogen. Therefore, I'm saying that, practically, I think you would maintain around about 50, 60 mg sort of thing chronically, and then put him on some kind of a low-grade anticoagulant of some sort. This fellow is off. Now he's on aspirin. He was on aspirin before. Now he's off everything. Now he's okay. But he's walking with prosthesis. So like that.
Sure. Thank you so much. I think we've had a wonderful 1 hour, and I would request Joseph to close the session.
Yeah, thank you all, and thank you for accommodating me for coming a little late. I got a little distracted in between, and nevertheless, I could catch the discussions. And thank you so much for this enlightening session. And thank you, Chaitanya, for summing up. And I forget the resident's name who presented this case, Dr. Sushma, right?
Yes.
Dr. Cecil? Yeah, Dr. Sushma for presenting this very well, and Dr. Cecil for adding the spice with the MMR data there. It was a good slide to show and look at, and thought-provoking discussion subsequently from Chaitanya for really summarizing the whole thing, and Dr. Sitaram for adding the essential questions, and Dr. Biju for really summarizing it. Thank you so much, and over to Diksha.
Thank you so much, sir. So to summarize, thank you all for joining us for episode 7 of Blood, the Life Savior. Today's session focused on an emotionally and clinically significant subject, recurrent pregnancy loss in a rare bleeding disorder. Through this case, we not only revisited the diagnostic complexities, but also highlighted the crucial role of hematologists in improving maternal outcomes. We extend our sincere thanks to Dr. Sushma for presenting the case with clarity and precision, Dr. Chaitanya Balakrishnan, and Dr. Sitaram for their engaging and thoughtful discussions. And a special thank you to Dr. Cecil Ross for his expert insights and a powerful concluding summary that brought the session full circle. We also acknowledge the continued guidance of our course directors, Dr. Biju George and Dr. M. Joseph John, whose vision continues to shape this academic journey. On behalf of Intas Pharmaceuticals, thank you to each one of you, including our viewers, for your time, presence, and commitment to learning. We look forward to welcoming you again on episode 7, coming soon with yet another unique and relevant case from the world of bleeding disorders. Until then, stay inspired and keep learning. Good evening and thank you once again.
Thank
you, sir.
you.
Thank you, everyone.
Thank you, everyone. Thank you.